Good afternoon, everyone. Good afternoon. It's a good morning, sir, for you because I guess it's early morning.
It's about 7:30. Yeah, 8.
Okay. Okay, so we start. Okay. Good afternoon, everyone. I'm Dr. Zahida from Penang International Dental College. Welcome to the webinar series streamed live on Facebook page of PIDC. This webinar will provide knowledge to the dental students and young dentists beyond the classroom setting. You can share your comments, your questions on the Facebook page, and we will try to address the question at the end of the session. A reminder that we request everyone who have not registered earlier can still get the certificates. Fill in the form which is provided in the Facebook Live link, and we will mail you the certificates. We are honored to have Dr. Suresh Somasundaran today. It's a pleasure to have you, sir. Dr. Suresh has completed his graduation and post-graduation from Sri Ramchandran Dental College and gone on to pursue MFDS RCS from Royal College of Surgeons in England, FFDRCSI from Royal College of Surgeons in Ireland, and MSc from Dental Implantology, University of Bristol. He is currently working as an associate specialist in oral and maxillofacial surgery in University Hospital in Plymouth, UK. Dr. Suresh is an adjunct professor in PIDC. He is also a trainer for Southwest Deanery for General Dental Practitioner and Dental Care Assistants in developing minor oral surgery skills. He is also the clinical governance lead for MaxFax Combined Dental Specialties for University Hospital of Plymouth NHS Trust. Allow me to introduce or welcome Dr. Suresh for the webinar series. Handing it to you, Dr. Suresh.
Hi, thank you. Thanks for the kind introduction. Am I okay to share my screen? Can you all hear me? Good morning, all. I'm just waiting to confirm if you all can see my screen, actually. Hi. So thanks to all the colleagues and friends around the world who have got me where I am today, and thanks for this lovely opportunity to Dr. Lahiri and the team, and my really good friend Kamraj at PIDC, who has helped me share some of my knowledge, which I've gained over the last 20 years. What I'm basically going to talk about is what I have found in my own clinical practice, is what has given me what I consider as long-term success in the field of dental implantology. This is a big topic in itself, and what I'm going to give is just a kind of a recipe, what I have gained and what I've found to be very successful in clinical practice. And I hope this can help you in your clinical practice at some day in not so distant future. All right. So my background, like Zahida said, is oral and maxillofacial surgery. And although I did my thesis when I was in my master's is on implant long time ago, things have changed in the last 20 years. And we are going into an era where everything you do is looked in minute detail. So we need to make sure our work and what we provide for our patients is of higher standard. And that is what I do tend to practice in my field. And I hope you can gain some valuable information from this presentation. Right, so this is where I live and work. Plymouth is in southwest of the UK, and it's a small city, and we have a population of 250,000, which is like 2.5 lakhs. So it's not a big city, but it's a beautiful part of the world. We have lovely coast, we have lovely sea views, and we have the hills and mountains. And the hospital I work, which is in the bottom right, the Dept Hospital, is a big university teaching hospital in this Western Peninsula. We are the regional trauma center, we are the big cardiothoracic center, neuro center, and a maxillofacial surgery where I work is a relatively small team of 4 consultants and myself, including myself. It's a fairly busy job, and this is where I don't do my implants. My implant practice is primarily outside the hospital. And so the photographs which I'm going to show you in this presentation is all from my private collection. So I would be most grateful if people can avoid sharing it to others. And if you want some of these images for your own information purposes, please let me know and I can share them individually. Right, let's go to the objectives of today's talk. Let's understand what is success in dental implantology and how do you define what is success. And let's look into how if there are any techniques to achieve that and whether we can achieve those long-term successes. Like anything in surgery, there's always going to be mishaps, pitfalls, and whether we can highlight on some of the common things when things go wrong. And finally, on the medical legal implications of things when things don't go to plan. Before we begin anything, we need to understand what's the success of implants as it stands. I mean, this ITI statement is about 18 years old, but I think it's still true in most sense. Most implant-supported restorations tend to be fine for the first 5 years. But things start having issues biologically and technical complications occur in almost half the cases after 5 years in function. But the issue in clinical practice is we tend to lose our patients for review after 5 years. And so we don't know whether these patients have implants which are functioning, but are actually ailing. When I say ailing, I mean they are in the mouth, they haven't fallen out, but they're not in the best health. So this is a valuable information to keep in mind when you advocate implant work to patients. That survival of our implants in 5 years is only 90.1%, which is not bad compared to any other sort of dental treatment. But after 10 years, it does drop down to 82%. So sort of 20 cases in 100, every 100 cases may have serious issues in 10 years. And that's something you need to inform your patients who are going to be investing a lot of time and money towards the treatment. And let's look at what is success criteria. I mean, this is an old article by Albert Kretsen and his team from Sweden. I've heard him talking a few times. And he came up with this criteria, what he thinks should be the norm to define success in implantology. That is that implant should be immobile. Second, there should be no periapical radiolucency, like you see on the radiograph on the top. And B, that the vertical bone loss or crestal remodeling you get after 1 year after restoration shouldn't be more than 0.2 millimeter annually. That means you need annual x-rays to confirm that. And obviously there's no signs of bleeding, periimplantitis or periimplant mucositis. So I've put 2 radiographs to show the top one is something which it's in 2 years in function, and you can already see there's significant periimplantitis. And that implant probably needs to be removed and restarted. And that's one of my own case. I can't explain why it happened, but it happened. The bottom one is one of my other cases on a patient who is heavily medically compromised. But that implant's been functioning for 5 years. And the bony remodeling you see is within norm because that's a tissue level implant. So that's a normal appearance. Just point of note, the top radiograph is of a fit and well young patient, and the bottom one is of a really old chap with lots of health issues. So I don't know why things went wrong, but they can go wrong. So success obviously in implantology is very important, but how is it measured? Like you said, you can use Albert-Kirtzen's criteria, but I believe in a practical way, you have to have a bit more understanding what would constitute success. Are we looking at the longevity and survival of the fixture and the processes, or any associated morbidity? Or are we looking at, after 10 years, is the patient being able to chew and bite to his maximum capacity? Or whether we have managed to achieve some improvement in their perception of themselves, about their satisfaction. Or this is classic an example for elderly people who have implant-supported overdentures, whether they feel having the treatment has helped them to get back their old life in a sense. And it's commonly highlighted in many articles, the most satisfying treatment in implantology is when you give an old patient a well-fitting denture on implants, and they realize that they can chew and eat without pain and discomfort. And that's the best thing you can get from. And also you got to bear in mind economical costs, because placing implant is just one part of it. Maintenance cost, it does cost a lot of money. They need to come for annual review. They need to keep their hygienist appointments regularly. So all this, you got to make sure that it's worth before you define what is success. So in my mind, I would say if an implant is working fine with no problems in 10 years, I would say that's a pretty successful outcome. We don't know what's the long term after that, but there are evidence that implants can be functioned with no problem in 20 years. And I hope all of our works do that. This is a lady who had an implant work done 3-4 years ago and came to me with some issues. Basically, the implant itself is fine, but obviously aesthetically it was not the best result. Although it's an upper premolar, in a wide smile, she was able to see the space distal to the canine, and she wondered whether we can do anything about it. So this worked fine for 3 years, but then at the end of 5 years, this was the status. So I would say that's probably not a successful outcome, because you want something like that with no aesthetic issues for at least, say, 10 years. Just to show you some highlight issues of when implants, when placed properly or were not placed properly, you can clearly see on the top right where the implant is too far facially angulated. So it's a matter of time that implant is going to lose all its buccal bone, and you'll end up with a longish crown, which you can already see on the top right image. Or the bottom image where the restored crown's aesthetics, and this is a different patient, but the color match and the appearance is not probably the best outcome. It is a functional implant, but in terms of aesthetics, I don't think we fulfilled what the patient was expecting to. This is what we really want to achieve. This is one of my own initial cases. This is 5 years in function. And what we have is a homogeneous restoration of tooth and implants to a point that for a naked eye, for a non-dentally qualified person, it would be quite hard to know which is an implant retained restoration and which is patient's own teeth. So what you want to have a good pink and white aesthetic. And this is what you want to achieve in every single case. And we understand that it may not be possible, but this is what we want to try and aim. And if something like this lasts for 5 years, there's a good chance that she might be able to keep that for 10-15 years with no trouble. I don't know what happens after that. And in my practice, I generally tell patients that I can only guarantee what happens for the next 5 to 10 years, but I don't know what the biology does in that time. So this is what we want to aim to achieve. This is again one of my patients. It's 9 years post-placement. There is some crustal bone remodeling, if you can see on the radiograph, but after 9 years, the patient was quite pleased with the result. She's got a good pink and white aesthetic score. It's pretty harmonious. The restoration could have been shaped a bit better, probably, but this was one of my earlier cases. and as I was still new to the job, I was quite pleased, and the patient is still pleased. She comes and sees me every 2 years for an annual X-ray. She has no worries. I tried to convince her to change the crown, but she was happy. And these are all screw retained crown, by the way, so changing the restoration is fairly straightforward. This is fairly another recent case 2 years ago. Patient with an ill-fitting upper denture was keen to have an implant, so placed an implant, and they were restored after 8 weeks of osseointegration, and the radiograph in the bottom is taken 2 years later, and it's well restored, good maintenance of pink tissue, and the patient was quite pleased with the result. And this is what we aim. This is again one of my own patients. This patient had an upper left tooth, the upper lateral had a single narrow implant placed with screw retained restoration. But as part of my assessment, I did warn her the upper left one had bone loss, and that's where she will never be able to gain the papilla back. She was fine with that, but once the restoration finished, she came back and she said she's not happy with the implant. And I said, well, there's nothing I can do to the implant, because the implant, in my opinion, is placed in the right position. It's the tooth next to it, which is a problem because it's lost that vertical bone, and which, as you know, anyone who's done GBR or bone regeneration, vertical bone regeneration is one of the trickiest thing around a single tooth, unless you do big block grafting. And this lady is in her 70s, so she wasn't keen for all that, and she didn't even want to have the tooth removed. But this is not an aesthetically good result, but functionally the implant's fine. But we'll have to wait and see whether that tooth will eventually fall and whether I can do something to change that things. So let's go back to basics. So what do we, when we diagnose a patient and get them ready for an implant, what do we bear in mind? First thing, in my opinion, is we need to understand clearly what is the patient's expectations. We need to know, why is that patient coming to you for? Is it just to have a tooth? Is it just to have an implant? Because you've got to bear in mind, patients don't know about implant. To them, it's just a screw. You could tell them it is Straumann, Astra, Nobel, I don't know, Biomet, or whatever. They don't care. To them, it's a titanium screw. What they want is a tooth which is fixed and as close that mimics your natural tooth. And you got to get it right in your first 2 appointments in your consultation, is whether you're able to achieve that, or do you feel the patient's expectation is something you cannot achieve, or the expectation is quite more than what you can offer. Then you might want to say that, well, this is beyond my ability and I might have to refer you to somebody. You got to obviously look at their medical status. Smoking is talked big time. I have placed implants in smokers, but I'm always worried. But as a rule, I wouldn't place a big graft or a sinus lift on a smoker. But if it's a smoker and he understands the risks, I would be happy to place an implant, but I would be wary of doing any grafting work. You've got to look at the smile line. So it's easy to treat the gentleman with the mustache because you can hide behind his lips, but it's not so easy for the lady down on the photograph below. Because anything you do, and if it doesn't go to the plan, is going to be obvious. You've got to look at the quality and the amount of keratinized gingiva. You've got to look at the restorative contour of the tooth. What shape of the tooth are we going to achieve? And you've got to make sure that is the site where you're placing the implant is free of infection. You've got to look to patient-related factors, medications they're taking, parafunctional habits. When I say parafunctional habits, I mean bruxism, grinding, clenching. These can be big factors in late complications, especially technical complications. You've got to see whether you're able to place the implant in the correct 3D position. You have to look at the quality of the tissue available, whether there is scarring from previous surgery. An example would be previous episectomy, previous abscess where they've drained, and what's the quality of the soft tissue you have. And again, you've got to look at the anatomy of the local area, sinus, nasal flow, ID canal, etc., and also the interproximal bone. And I feel this is a very important slide, and quite a lot of, when I train people in implants, they ask me, so when do I say no to patients? Well, I always say that I can't tell people when to say to their patients when they don't want to do implants. It is your own gumption. That comes from experience. That is your own clinical judgment, whether you feel you want to treat this patient for whatever reason. It could be the patient's expectations. It could be your limitations as a surgeon. It could be that the patient is not suitable for an implant. There could be any reasons. But the one thing bear in mind, there is no absolute contraindication. They're all related contraindication. I've heard of people who have placed implants even in patients who are on oral bisphosphonate and they're being fine. I've heard people who have placed implants in patients with severe medically compromised conditions and have been fine. But would I place them? Probably not. So I think this is one good way of distinguishing them. So we could say, where are the high risk conditions, like serious systemic disease, immunocompromised people, HIV, medications, chemotherapy. Those are not the patients you would want to be thinking of placing implant, at least in the early part of your career. If the patients are desperate for implants, I would probably work along with some very experienced colleagues or mentor to help and plan those patients. Patients with significant psychological mental problems, dementia, Alzheimer's, those are patients you don't want to be doing implants. You don't want to make their life worse than where they are. Any sort of alcohol-related abuses because they won't be able to look after themselves or their implants. Significant risk, heavy smokers, irradiated jaws, uncontrolled diabetes. We're beginning to see a lot of literature on it. And obviously, patients with bleeding disorders. The level of evidence for absolute and relative condition in systemic condition is very low. And this was very well published. It's a good journal to read about systemic conditions and treatment risks in implant. I would recommend young graduates who are interested to know a bit more on the risks to look up this article. It's a really good paper. So for obvious reason, comparative studies looking at implants in patients with and without systemic risk factors is not possible. It will be an ethical dilemma to get an ethical approval. So in short, what I would do, I would get a good medical history, identify potential risks, and discuss with the patients. And you have to bear in mind there are certain procedures, certain conditions where the placement of implant may actually make the patient worse off. And that is the ones I would avoid. And the classic example will be risk of hemorrhage in people who are on oral or IV bisphosphonates. I would probably not place an implant because the risk of causing them osteonecrosis is quite significant, and you wouldn't want to place an implant those patients. But in certain conditions like diabetic patients, osteoporosis, or maybe smokers may be in that category, the implants can fail, but hopefully you won't put the patient in a worse off situation where they started off. This is again a good aesthetics in anterior implants is a big thing, and this is a good ITI toolkit available. I think you can download it or you can access it anywhere online. I use it in my practice for anterior implants. I have it in my case report. I have it in my computer, in my system. So any patients who needs anterior implants, I kind of go through this systematically. I look at them whether they are low risk, high risk, and this is self-explanatory. If you can get hold of this, and it's a good way to look at things. And then anything red, if there are multiple reds, then I tell the patients that we may not be able to achieve what they want, and you've got to have a frank and open conversation that implant may not be the best option. They might have to consider a bridge or stuff. But if the patient understands that, okay, no, I understand, but I would still want to go ahead, then you can go ahead. But then you've got to make sure the patient is aware that you cannot achieve everything the patient wants to. Just to break the monologue, this is an anterior case which I did. So it wasn't an immediate placement. It was an early placement. So typically I place my implants 6 weeks after extraction, and I do a GBR in 95% of my anterior cases. And I'll go through my technique in a while. And then after 8 weeks, they get a provisional restoration, and that's the final restoration. Both the teeth on either side are heavily restored, and I did tell the patient to see their own dentist to see if they would like to change the contour and the shape of the teeth. They were not too fussed, but I think it's a good result at the end of, that's probably 2-3 years old now, but good healthy gums, good keratinized gingiva, good contour, and in the end, it's a good result for the patient, and that's what you want to achieve. This is a lady which was 6 years old now, 6 years ago. That was her restoration when she came to me. I don't know if you can see the arrow mark, is a broken down premolar. We discussed the options, including referring to the endodontist for a root canal and post-crown. The patient didn't want to go through that, and she finally agreed to have an implant retained restoration, and that's the end result. And she was quite pleased with it. This is one of the cases which I'll go through in detail later on. Just to show you similar cases of implant retained bridge and multiple failing teeth. Again, the patient didn't want to go through any other restorative options, which some of you out there might think, those teeth could be root treated, post-crown. But the patient had enough. The time and effort she spent on those teeth, she said, just take them out, and then she wanted a fixed option. And that's what we did. We removed the tooth, let it heal up after 6 weeks, 2 implants, a bit of a GBR, and restoration, and that's the end result. And I think it's a pretty harmonious. They're all screw retained restorations, by the way. It's a pretty good result, and considering she's actually had a big smile line as well. This was the earlier case I showed, but this was taken 3 years later, the radiograph, just to show upper lateral extractions, 2 implants, GBR, and we've done a big lip, a smile line, high lip line, high smile line. Anything you do, and if it doesn't go to the plan, you didn't have a end result in mind when you started off, you would have been caught out. And every time the patient smiled, it would make you realize that, so I still see her. She's one of the senior managers in my trust, and every time I see her in the corridor and she smiles at me, I feel happy. I don't do that many immediate. This is one of my initial immediate cases I did. It was a good case I thought to try on. Low lip line, low smile line. And it's a man with a thick labial plate, good keratinized gums. So I extracted, placed the implants. I didn't restore it immediately. It's for no other reason, but I find immediate restoration very fiddly. And so I tend to leave it. And then I take impressions and get the lab guys to make the provisional. But people do that all the time, and it would be a good option to do it. So this is how he came, and this is how he left after 3 months. So I took the root stumps out. We placed the implants immediately, and then I brought him back in 8 weeks, made some provisionals, and then after that is his final restoration. Pretty harmonious. His particular trouble was he didn't look after his teeth, so you can already see decay in the upper right canine, possibly in the upper left canine, and he's a builder, drinks lots of heavy fizzy drinks and sugary drinks, so doesn't look after his teeth well. So I've told him that he's going to keep me busy. Aesthetic. This is a particularly aesthetically demanding patient. She's had, I don't know if you can see the scarring on her lip. She had multiple trauma over the years. Her upper left lateral, as you can see, is slightly discolored and pushed labially from a sporting injury. The lateral was sticking out. She never wanted to have orthodontics. She just wanted her teeth, the canine back instead of the denture. So I placed an implant. That's the final restorations. Although to me, that was pretty good result. The patient still feels it doesn't feel like her own canine. And she still complains to me that, oh, it's okay, but it's not what I wanted. And I don't know what else I could have done. If any of you out there could give me valuable tips, and I would welcome to know about that. But I thought it was a good result, considering where she started off. But she comes to see me every 2 years, and I dread to see one day when she comes and say that I don't like it, I want it removed and start it again. But obviously, if I'm not able to meet her expectations, I won't be doing that. So, considering all this, so what I feel is a good way of looking at what is success in implantology, I think this is a good publication as well, is whether you're able to satisfy your patient, whether your prosthesis is stable in the patient's mouth, whether you've achieved a good aesthetics. And you've got to bear in mind, a successful implant osseointegration is only half job done. In fact, it's less than half the job done. what you want is your restoration or your prosthesis on it to be as good as it can get. But in the end of the day, that's what the patient wants. The patients want the tooth. The screw doesn't matter. Just go into GBR. So as I mentioned before, 95% of my anterior cases, I would do a GBR. And there's so many good articles and publications and so many experts out there who can explain it better than me. But one chap I would ask you to look into is called Danny Boozer. People who don't know him, Professor Boozer is recently retired. He's an oral surgeon in Sweden. He's sort of the head of the implantology program in Bern, University of Bern. He's done extensive studies, research on guided bone regeneration, and he probably has one of the long-term results. And now his deputy, Vivian Chapu, has taken over, and she's brilliant as well. So you should probably look into it. A few things to bear in mind about guided bone regeneration. It's very predictable for small to medium bone regeneration. However, these studies published on GBR have low level of evidence, and this was confirmed by Hammerelli. Hammerelli is a big implant field. Lots of prosthodontics might know of him, Professor Hammerelli, and he's a well-reputed guy in the implant world. So the evidence by Cochrane in 2009 shows GBR can be effective, but complications can arise. It's reliable in between when you want to gain 2 to 2.5 millimeter, and its success is similar to those if you have implant completely placed in native bone as opposed to grafted bone. So it does work, and in my take from all of this, it definitely works. But you got to be worried that it can sometimes fail. Sometimes you do everything as you do as per your training, but still things don't work. So it's very technique sensitive, I feel. And certainly in my career, I've had a kind of a learning curve. My initial cases, I didn't achieve as much as I sought out for. But increasingly, I'm seeing more predictable bone regeneration, and I'm able to achieve it. So this is the chap I was telling you, Booster, and this is a good baseline article to look at about how to place an implant, you know, the position of your implant, the depth, and the danger zones and the comfort zones. So basically, if I were to tell you in a nutshell, the implant has to be placed in the ideal 3D position, and it should be restoratively driven. So you need to have an idea how your final restoration is going to look, and you've got to plan backwards where you're going to place the implant. So you can use study models, Waxer, CT, guide, whatever. It doesn't matter. At the end, you got to place the implant in the right position, and there's usually only one position where the implant can be placed, especially in the anterior cases. And you want to make sure that it is in the right depth, which is usually 3 millimeter from the CE junctions of the neighboring teeth. You don't want it too deep. You don't want to be too shallow. You want it to be in the right position, and that will determine your bone, your papilla, and everything else along with it. Please read this article if you get a chance. So let's start from stepwise. This is for all the undergraduates. What happens in implant surgery? So you read a nice wide flap. So if you go in a clockwise direction, starting from the top right, and that's the sequence, big wide flap, and then you inspect the side. You see there's a little fenestration there. It's from previous sinus infection. All my implant placement is done by a prosthetic guide. That's my guide. It's a simple guide, not an expensive 3D printed guide. Just get the lab to make me one. Then I place the implant in the correct depth. I had to do a small GBR. I don't know if you can see the little membrane covering over the implant. If I didn't achieve a good primary stability, I think that's what happened in this case. Probably I over-prepped it. I closed the site, and then I exposed after 8 weeks. And that's an RFA kit, Osteotel system, which to check whether the implants achieved good primary stability, which is usually 70 or 80 ISQ. Anything above 70, I would be happy to restore. And this is what you want to achieve. You want a good keratinized gingiva all around that implant. It's 2 different patients, just to show you what we're looking for is nice, healthy keratinized gingiva. When you remove the healing cap, there's no bleeding, there's no suppuration, and then you know those implants are ready to be restored. We take a standard impression. My technique is, I'm not a prosthodontist, so I follow same technique every time, and it works for me. I do an open tray technique. I put an impression post, cut the hole in the tray, pick up with an imprigum or a putty or light body silicon, and then request the lab to make me screw retained crown, make sure the models are articulated, check for occlusal interferences. And this is where we started, and this is where we end. And that X-ray was done, I think, after the second review, which is usually 12 months later, and good, healthy crestal bone, screw retained restoration. And if she was to lose any other teeth, I could incorporate into any future bridge. Another similar patient recently done. So this was done by one of my trainees who was there on the day. She wanted to do a presentation. She took it on her camera. So I apologize for the quality of the image. It's from an iPhone. So it's a 3-sided flap, and I make sure my angulation. So this to show you is restoratively driven. I didn't have a guide on that occasion because I think I forgot. I was probably busy. But that the implant is made sure it's held on the palatal wall, and it's just off the incisal edge of my future teeth. So it could be screw retained restoration. The image on the third image on the right side is to show the depth of the implant, which is about 3 millimeters to 2 to 3 millimeters below CE junction. On a lateral, you can go just about 3 or below 2. I think on this case, just to show you, it was just about 3 millimeters. Although the implant was well enclosed in bone, I did a bit of a contour GB, and my go-to is a Xenograft. For those who don't know what a Xenograft, it's from animal origin, other species. So typically I use a Xenograft. I probably can't tell the make I use is Bios, made by Gashlik. The membrane is BioGuide. It's a collagen membrane. I tuck the membrane around the healing cap, put the membrane in, close everything up, and then come back in 8 weeks. This is what I tend to do in my anterior case, and it works fine. This is another example where we did a comprehensive treatment plan. The chap came with a failed post-retained crown, but he had multiple other problems, as you can see in the images. And I asked him to get those teeth sorted. He had a lot of composite work done by my colleagues. He came back to me, placed the implants, and that's his final results. He's a young 21-year-old chap, and it's a good result. And I think we managed to get the papilla back. And probably a bit too wide for me, but that's what the patient wanted, and he was going to get the rest of the teeth whitened as well. So that's his final zirconia crown. Going to a bit more extensive work is what happens when you don't have any bone to place an implant, when you can't place the implant in 3-dimensionally the correct position, then you want to augment it before you place. This is an example of a patient's CT scan which shows cross-sectional sagittal where he has no label bone, and he's got a huge nasopalatal nerve canal. So we can't place an implant in these cases. So what we did is we grafted it. And this is post-graft CT, which shows, you see the 2 pins of my screws. He had a chin block taken from his anterior symphysis, blocked it. These were all done under local anesthetic, not under general anesthesia, maybe a bit of sedation. So took a label cortex, filed it out, screwed it in, let it all reintegrate, and come back in 4 to 5 months. We had solid bone. And that's the planning, and then that's when the implants were going to be placed. I've still left the screw there, which I would remove obviously at placement, after placement, just to show you that in some cases you need to graft ahead before you can actually place. So this was done as a delayed stage procedure. Sometimes you lack bone vertically. You're not enough height to place a standard implant, then you do a sinus lift. So this is an internal sinus lift where you go through the osteotomy where you prepare to place the implant, and you tap the sinus flow superiorly into the sinus, and you can see a dust of bone on the top X-ray. I don't know if you can appreciate, there's a dust of bone. That's where the sinus lining is pushed up. Then you thread your implant in, make sure it's good stability, and then finally standard screw retained restoration, and that's been in function. And you can even start seeing the new sinus flow being remodeled. This is possible when you can ensure that you have adequate vertical height. I would personally say if I have 4 to 5 millimeter of bone, I would go for an 8 millimeter implant and use a internal sinus kit, either using my Versa burrs or a standard osteotome. Sometimes there's lack of bone. Those cases, on the ones you're seeing now, you can't place an implant. There's hardly any bone for any stability. So this one needed lateral sinus lift, which is a kind of a modified Cadwell loop procedure. Tatum started it, and then that's what I did. I made a window, pushed the window away, lifted the lining, lots of autogenous bone mixed with 60% autogenous, 40% mixed with BIOS, Xenograft. Let it all sink in and heal. And I would normally leave it for 6 to 8 months. Take always a second CT. Quite often, people don't repeat the scan once they see the OPG and they think there's a good image. But you've got to make sure there is bone towards the medial aspect as well, so that there is good round bone all around, rather than just don't rely on a two-dimensional image. You need a CT guide, CT scan if you're planning to do a sinus lift and implants. Let's look at the restorative options. So once the implant is all healed, you can either restore with a screw retain or cement retain. My personal preference is screw retain for simple reason of restorativity. I can take it out if the patient is not happy. I can change it. Patient loses another tooth. I can use it to modify my restoration. And the biggest thing I find with screw retain is provisional restorations. So this is for those high expectations patients who want their aesthetics as natural as possible. You don't want to give them a final expensive restoration straight away. You want to try and provisional restoration, see how the patient feels it's in the mouth. I sometimes leave provisional restorations for 2, 6 months, 8 months, and they come back and they say, actually, yeah, I like it now. Can we have the same for the final? Then I kind of copy that. It also helps in those cases where you don't have big inter-arch distance, where the mouth opening is restricted, access is tricky, and also biological complications are limited. Although there are modern techniques where you can ensure the cement doesn't go around the peri-implant area. The advantage of lab cemented ones are it allows for corrections of malaligned implants. It can be a bit more forgiving. Lab costs are very low. You can avoid the access screw hole, which might be not a thing some patients would like to see. So they was like, why do I have a hole on the crown? I don't like it. So those cases, you go for cemented crowns, and you maintain an intact occlusal surface because there's no screw access. So technically, the weakness of the crown is minimized. So this is how a screw retain crown looks. So you just, slightly on the cingulum side, so easy to access, easy to remove. This to show when a screw retain is not possible. This is clearly an implant placed to incline facially, and as you can see, the impression post when I tried it on, it was, again, it's not my patient. It was referred to me to see if I can correct it. It was difficult, so I had to tell the patient they either have the whole fixture removed, start all over again, which she wasn't prepared to. So basically, we removed the lateral, convert that into a bridge from the existing implant, and that's what she wanted. But you can't do a screw retained restoration on this. You can only do a cemented restoration because of the angulation error. You can't get a screw hole, otherwise it will come too far facially. Let's look at let's look at some publications in implants. There's no field in medicine or dentistry which does not have its share of controversies, and implants is probably one of the biggest field in dentistry where different experts have different opinions. You have one who says, socket preservation works, or some say socket preservation doesn't work. For the benefit of students who don't understand what the socket preservation is, sometimes you remove a tooth and while you wait for the bone to heal, you can graft the socket and come back in 4 to 6 months to place an implant. That way you avoid guided bone regeneration in the second appointment, and you're confident there is healthy bone when you drill the hole in. I don't do this unless the patient has specific reasons to say. The only time I've done it if the patient is going away or they're having some health issues, they don't want anything done for a year, so then I would graft it and say come back in 12 months. It's a controversial, so lots of evidence here and there. I don't do it, so I can't talk about it. Short implants, I do short implants, but will I do it every day? Probably not. If I can get a standard size length implant, which is 8 millimeter, I would. But if there are limitations, especially posterior mandible, ID canal, and patients don't want sinus lift, I would do shorter implants. And if I do shorter multiple implants, I always splint them. Biomaterials, do you use allograft, xenograft, alloplastic material. There are so many things out in the market. Which one works, which doesn't work, don't know. But I think when you start off as a trainee, stick to one thing, which obviously you work along with the mentor, stick to what you have seen and observed works, and stick to that. And with confidence, you can experiment. But I wouldn't go experimenting just because someone has said it works. And when I looked at it and I found that among the 100 most cited articles in dentistry, the first two are implantology and periodontology. So you can see, everybody's publishing these days on implants, and we don't know what works. So make sure you when you look at some new technique, you look at the science behind it. Make an effort to understand whether what the person is suggesting is actually effective. Another controversial topic is loading. I don't do immediate loading for single tooth. I could, but I don't. I've only done for full arch cases, like all on four cases, I would immediately load them. But then the technique of doing them is completely different. You're angulating the implants, you're putting longer screws, you're splinting them all together. But generally, if you want to immediately load, you've got to make sure the length of the implant is at least 10. You've got an ISQ of over 60, which is making sure the integration is going to be fine. And the insertion torque is over 30 newtons. So any implant-related topic, you got to remember where the evidence from. And for those benefit of those who don't know what this pyramid is, it's basically depicts how you filter through information you get in publications or market research or companies trying to sell you new products. Look at what is the evidence. Is that a systematic review? Is there a lot of evidence-based, was a randomized controlled trials? So this is the pyramid which depicts, as you go towards the tip of the pyramid, the evidence becomes better. Systematic reviews, meta-analysis, that's the best. And unfortunately, in implantology, there are not that many publications which has had meta-analysis and systematic review. And it is very difficult because lots of confounding factors and a lot of ethical issues. Split mouth study is not easily doable. There are a few topics which are, but not all. So when you go through when you come across any new publications, make sure you bear in mind whether the evidence there is actually something you can buy. Don't go for some case control reports or one or two case series. It might be effective, but will it work in your hands? Don't know. Complications. My opinion, most complications happen because of two things: lack of planning and issues with execution. Lack of planning happens with poor diagnosis, missed information. You miss something at your initial appointment. The first appointment when the patient comes for implant is very critical. You got to do every investigations to make sure you understand what patient wants, what the anatomy, what are you dealing with. The bottom right x-rays, you can see the patient has had two implants, and not just one, both have been through the ID canal. So the surgeon who placed it ensured the patient doesn't recover, and he's done it twice at the same time. The funny incident about that particular case is he went upon and restored those implants as well. And he completely forgot to see that the patient was numb. Although the patient did complain, he just completely ignored. In my dictionary, there is no excuse for that. And the second radiograph is borrowed from a colleague, just to show that implants planned without three-dimensional images can be a problem, or if it's done blindly using, it could be guided procedure. I don't know if it was a guided, it could be, or an immediate or a flapless technique. They are prone to complications if you don't plan. That implant might be functional because there's good 4 or 5 millimeter of bone in the top, so it might be maintaining it, but will it remain like that in 10 years? Will it be long-term success? I don't know. And the third radiograph is to show you lack of planning. So implants placed just to fill spaces doesn't work. It has to be prosthetically driven. You need to know what the end result, what you're trying to achieve. Infection at the site before you place an implant, making sure that the site is decontaminated before you place the implant is very critical. This is a late peri-implantitis, retro-peri-implantitis, in a sense that the periapical infection wasn't completely cleared off. The dentist went in and placed the implant, and that shadow remains, and it is going to disintegrate, and the implant is going to fall out. This again to depict when implants are placed as and when required, rather than treating the mouth as a one unit. Whoever planned it has just planned it as he went along. I mean, clearly the gentleman needs a full oral rehabilitation. Requires all his top teeth removed and start off all over again. But over the years, in the last 10, 15 years, he has had a number of implants placed. This was referred to me recently, and I'm stuck where to start. He's in his 70s now, and it's going to be very hard for me to discuss with him, saying that we're going to remove everything, start all over again. Because those implants were not planned prosthetically, and they're all cement retained, so they're not easy to remove them as well. So his lower jaw, I mean, he requires a lot of work done. Some of his teeth need to go. He might need further implants, but just good to depict when you do not plan your cases with time, how what you have done can actually cause more problems. This is something, again, some of my colleagues have shared with me. Clearly, those are Tatum implants, I think. So they've gone crazy with an implant for every single tooth. They work fine, but in 10 years they're going to fail, or it's already failing now. So what are we going to do then? And removing those implants are not going to be easy. This was a patient who traveled abroad to have implant placement, and those are Nobel implants. And you can see they have been placed without any sort of diagnosis or planning. And they're all failing. They've violated the inter-implant distance, which need to be respected. They didn't have any plan what the final restoration is going to be. And the patient, because of COVID, couldn't travel back, and he came to me saying, is there anything I can do to salvage those implants? Unfortunately, no. He will have to have all of them removed, grafted, and start all over again. So it's big, expensive corrections. So if you do not have a plan when you begin, you were asking for trouble. Like someone said, if you fail to plan, you plan to fail. So if you fail to plan your restoration, you plan to fail. Again, this one I showed you before, just to say implant completely placed without any respect to the angulation. Could be restored with a cement retained restoration, but long-term stability of that labial plate and the labial gingiva is going to be questionable. Briefly, I'm talking about medical legal issues. At least in the UK, in my experience, I can say that implant-related malpractice lawsuits are on the rise. The largest compensation, I think, a few years ago was up to $250,000. Claims have risen by 41% in the last 5 years. They're big payouts, and there could be indemnity companies who would refuse to indemnify you if you've had such a big payout. So you may not be able to practice your work. So you've got to ensure your patients are risk assessed, whether they're suitable for patients. Write a treatment plan, send it in writing, say they accept it, obtain a consent. And consent, what is consent? What's the difference between the image on the top and the bottom? Someone stabbing you and your surgeon stabbing you. The difference is the second one, you have given the surgeon the permission to do that to you. You agreed the surgeon can cut your abdomen, as opposed to someone stabbing you. And the whole difference, that is consent. You have given, your clinician has to have a consent from the patient saying that he understands the risks from the procedure. What can go wrong? What happens when things go wrong? Is there any fallback plan? And this has to be communicated effectively, maybe more than once, written down, documented, kept and stored. And in the UK, the legal requirements is we keep all records for up to 12 years after completion of treatment. I tend to keep all my implant works with me. It's the best way for you to defend yourself when things go wrong, which will happen. We don't want it to, but that is life. Things go wrong, and then you just have to have fallback. I'm coming to the end of my talk. I hope I haven't bored you. Some of the useful resources for beginners, I would recommend the Dental Implant. I think it's Stuart Jacobs' book. It's a basic book. If you're new to implant dentistry, just understand the basics. And then you have Carl Misch, who's like, I wouldn't say father of implantology, but modern implantology after Brandon Marks, somebody who has changed the way people think and do implant dentistry. Kalmish. Unfortunately, he's no more, but that's a good book. Every time you read, you learn something new. I still go through it now and then. So much information. For university, I don't know if you can have access to ITI website for students. They've got so many resources, so many publications on implantology. You can just go in there. You can get all the information: what works, cemented, screw retained, immediate, delayed, grafting, prosthetic. Every information is out there. You just have to find it. It is an expensive subscription annually, but I don't know if the university can get that, and then you can share it with the students. Thank you. That's not far from where I live. On a nice sunny day, you can go around, and so I welcome you all. If you ever come to the UK to visit my part of the world, it's beautiful. And since COVID, there have been lots of people visiting the Southwest, so I welcome you all. Thank you. Any questions?
Thank you, Dr. Suresh. It was indeed a wonderful talk. We are ready to open up for the question and Q&A sessions. So we have a question by Sonia Lee.
Right.
That with such extensive graft in the transcrestal case, is there a concern about the bone quality, especially the mid portion of the whole grafted site?
So let me get that right. So I can read it. With such extensive graft in the transcrestal case, is there a concern about the bone quality, especially in the mid portion of the whole grafting site in the center? Good question. So I mean, it's calcified mush, really. It's not patient's own bone. It's 50. I do put 50 to 60% autogenous bone, and then the rest is all xenograft. But when I drill in and I can see that bleeds, then I'm happy. So if the bone bleeds, I'm happy to put an implant there. If I drill in and there's no bleeding, then I would be a bit worried. What is the comfort of thickness of graft initial beds are able to reach through the whole graft? So basically, I use small particle granules. So there will be space between the granules. So the theory is the blood seeps in from the lateral walls of the sinus, and it will find its way in and form osteoclasts, osteocytes, etc. And the proof in the pudding will be if it survives after a few years, and it does work.
So we have another question, sir, by Andre. In regards to the case of the bodybuilder with fair, moderate, or oral hygiene, was the hygiene a concern before proceeding with the treatment?
Yes, he was sent to the hygienist 3 times, but he drinks so much of fizzy drinks that it was very difficult to keep him, disciplined. And I'm still worried he will come back for more implants, but I can only do what I can do.
Another question by Jason.
What extent does soft tissue thickness affect implant success, and how would you advise manage patient thickness? Right. So definitely, big. There's ITI guidelines has been published on the effectiveness of keratinized gingiva. It has to be. The thicker the keratinized gingiva, better it is. Male with thick bone plate, you can do anything and get away. The gum is very forgiving. If not, for thin gingiva, I always do connective tissue graft. I either take it from the palate, and I do it at the time of placement, or I use, biomaterials. I use mucoguide, fibroguide, mucoderm. I use something to bulk up the soft tissue. Or I sometimes use, at the exposure stage, I do palatal roll or any sort of perioplastic work to bulk up the label plate soft tissue. It's a very fiddly procedure. I learned it from a periodontist, and I went on a periodontist course. That's where I learned. So they masters that perio work, and they know how to work with perio soft tissues. So yeah, I do definitely. I would make sure there's good gingival tissue. An option to restore tissue thickness with biological. Would subcrystal implants be an option to restore tissue thickness? I didn't get what you're trying to say. Subcrystal implants. So the best thing I can repeat what I heard. There's a chap called Mario Rocuzzo. He's a periodontist implantologist. I think he was an ITR president, Italian guy, brilliant surgeon. So what he says is best. An implant should be as deep as necessary, as shallow as possible. So the idea is you should be able to get around there and floss it. You don't want to place it too deep. You don't want to place it too shallow. It has to be the right depth. And what is the right depth? That is determined by your respiration, where your crown margin, cervical margin is going to end. That is what determines. I use tissue levels. I use bone levels. And if I do bone level implants, I do place them subcrystal by 1 millimeter or 2. If I'm doing full arch, I use neodense system, which I place 2 millimeter, 2.5 millimeter subcrystal. I guess if that answers your question.
So I have a question.
Sure.
Like, what do we do for implant maintenance? What all can we do?
Yeah. So I have a consent page which has got all the information. It's just got like 10 pages, which the patient gets. Every patient gets that, and they sign it. So in that, they, depending on their oral hygiene, their BPE score, their plaque score, I tell them. So if they are high risk, they go every 3 months to the hygienist. If they are low maintenance, they go every 6 months. But they have to come and see me every year for a radiograph. So I don't, because I only visit to do oral surgery and implantology. I do send them to their own referring practice, because I work in a referral practice system where patients get referred to me. So I send them back with a plan that they need to see their hygienist, and this is my advice, and they sign it. Now, whether they follow it or not, I don't know, but I try my best.
So we have a question by Sonia Lee. Block versus graft, which is your preference, and when you indicate one over the other?
Simple. If I can't place the implant in the right 3-dimensional position, then I would graft it first. I would either do particulate stage graft or I do block graft. And this itself is a big topic, and I didn't go into it. It depends on the residual anatomy. If it's a 3-wall defect, 1-wall defect, so I don't know if you guys are aware of it, depends on if it's a 3-wall defect and there's only 1 wall missing, then it's very predictable to grow that 4th wall back. If it's a 1-wall defect or 2-wall defect, then it becomes unpredictable with GBR. Then I would definitely go for a block. So because my training is in surgery, I don't have any qualms in taking bone from the chin or the hip. When I do in the hospital, I do a lot of iliac grafts, or I would take it from the ramus area. I would take a Corey plate, and then I would use that and graft it. So it depends on the anatomy. So a scan would tell me whether I would need to block it or I need to particulate graft. And again, it's a big topic. I can't discuss it in 1 hour.
Thank you, sir. So
I've got a question from Tina. Immediate implant placement indications. Okay, 3 things. You need to have adequate training. Good thick label plate, at least 1 to 2 millimeter. No infection in the site. Thick keratinized gingiva, if possible. Go for it. If you're a beginner, don't go for the anterior cases. Maybe a premolar would be a good one to start with, because it's technically could be sensitive if you're not used to it. So, or work with a mentor. I've probably done very few immediate, and I don't restore them immediately. So that's why I feel no advantage. So I tend to leave it for 6 weeks. My go-to is early placement. Take the tooth out, come back in 6 weeks. I've got good keratinized soft tissue to work with, and I can use the granulation tissue which goes into the socket. I peel it out. I use it as soft tissue graft over the membrane to bulk up the tissue. That's my way I've done it, and it works.
we have a question from Dr. Lahiri. How many weeks after healing can you place implants for a COVID case?
Oh, good question. I would say if the COVID patient's been post-COVID 2-3 weeks, I would go for it. 2-3 weeks. Yeah. I don't think anything to do with COVID implant is AGP at all, unless you're doing sinus lift. Do you guys follow that AGP, aerosol generating procedure, or not?
Yes, sir. Yes.
I don't think drilling implants is not an AGP, because the speed is below 1,000. Your drills are. If you're doing sinus lift and using piezo kit technique, maybe yes. So I would say 3 weeks.
Okay, sir. I think that's all what we have for the questions. So that's all the time we have now. So we request everyone who have not registered earlier can still register fill in the form, which is the link which is available in the Facebook, and you will get your certificates emailed to you.
So I've got another question from Sonia Lee. One more curiosity: hip graft versus ramus block. Is there a difference in the resorption rate? Yes. Hip tends to be more cancellous. So cancellous bones are soft. They have good vascularity, high rate of resorption. Ramus thick blocks, cortical bone, less incidence of resorption. Ideally, you need a bit of both. So if you can have a plate which is like a ramus plate, and you have a cancellous bone which is like your iliac bone, that's the best combination. So what I tend to do my block is I thin the block down, and I take a lot of cancellous component from that defect, and I pack it in between the plate and the defect. Would you immediately load implants, say, for a mandibular overdentures case? Yes, I've done it. If the implants have achieved very good stability, I would. It definitely improves the patient's outcome. Yes, I would do it. I know there's a limited, but is it mainly for splintered bar cases? What about your splintered cases? Splintered overdenture. Yeah, I mean, so actually, to Patrick, I'm going to go back to your question. If the implants I place is of sufficient dimension, so if it's a standard size implant, not a narrow implant, which is below sort of 3.5, if it's a 4 millimeter implant, I would immediately load it. Obviously, you can't splint and bar them immediately because you need the lab facilities. But yes, you can. Maxilla, I would be a bit worried. Mandible, yes. Again, to all the guys asking questions, you've got to see, it's my implant practice is purely private patient fee-paying practice. It's different from a nationalized or academic institution. So I can't afford to get things wrong because reputation and cost. And like someone said, if you have one implant failing, one GBR failing, it wipes off your profit for the next 3 or 4 patients. So if you've made money, say, for the first 2-3 implants, all you need is one big failure. It wipes out all your profits on the earlier cases. So you got to in private practice, you got to play it safe, and you got to make sure what you do works 99% of the time. I'm not saying 100, but that's what the aim is.
I guess we have that much questions only. So thank you once again. Thank you for joining us today. We thank all our viewers, and especially the speaker, Dr. Suresh, who took time to speak to us. You can follow us on Facebook and Instagram for more such relevant topics and webinars. That's it from us. Best wishes from Penang International Dental College. Sorry, sir.
Thank you. All the best, guys.
Take care and stay safe.
Bye.
Thank you. Thank you.